Hi, Councilmember Rivera, Councilmember Rosenthal, thank you so much for hearing our testimony. My name is Katie McFadden. I'm a midwife, a registered nurse certified in neonatal intensive care, and a volunteer and organizer with Ancient Song Doula Services. I just want to highlight the things that we haven't talked about yet. We've talked a lot about racial disparities in maternal infant health outcomes and the root causes to that. We've talked about implicit bias and lots of other things, but the driving force of racial disparities in New York City is the lower quality of care provided at a concentrated set of minority-serving hospitals. So we have a 2016 study that showed that if Black women were going to the same hospitals that white women were going to, the severe maternal morbidity rate would drop by 47.7%. That's half. And we have the same researcher put out a different study in 2018, again, looking just at New York City hospitals. So this is, germane to us specifically and really no other place in the nation, that if Black babies were being taken care of in the same neonatal intensive care units as white babies were, the differences in morbidity rates for very low birth weight babies would drop by 40%. So in the research, those hospitals are anonymized, but if you are familiar with the landscape of New York City, it's really Kings County, Brookdale, and SUNY Downstate. Half of Black women in Brooklyn give birth in one of these three hospitals that have a severe maternal morbidity rate 6 to 9 times higher than Maimonides, which is less than 10 miles away. So the driving force, so why is care at those three hospitals so much worse than all of these other hospitals? And I think along with historical racism, which excuses some of the behavior in the minds of people with power who work in those institutions, a lot of it is the resource deprivation to the public serving hospitals, because Medicaid pays about half as much for obstetric services that private insurance pays. So if you have a hospital that serves a disproportionate amount of people on Medicaid, you're going to have half as much money coming in, and that literally does not cover the Band-Aids, the salaries, the keep the lights on to provide adequate standard care in the year 2019. So the fact that Medicaid reimbursements are unequal is tacitly admitted to within the legislation because there's a separate pool of money called the disproportionate share hospital pool. And in most other states, that money is used as it is intended and goes to the hospitals that serve a disproportionate share of hospitals. However, in New York, there's a law from Albany that divides that money into two pools, one for the private hospitals to divide into and one for the public hospitals to divide into. So, for example, in 2016, NYU served 18 times fewer patients on Medicaid than Elmhurst did, but got $5 million more from Albany to compensate them for that care. So the fact that the money isn't actually ending up in the institutions where it's needed has caused decades of hiring freezes and layoffs so that there is almost never the recommended amount of staff working at any period in time. In 2000, I graduated from midwifery school in 2017, having just recently learned about these disparities, and I did not want to take a position as a midwife working in a system where I would be perpetuating medical racism without understanding how or why. And so I stayed in my position as a NICU nurse at SUNY Downstate. I sent an email on August 8th saying we are incredibly understaffed. What are we doing to get more staff here? August 9th, DeCesca Floorman died, a mother of 6, from understaffing related causes. In the next 4 months, I sent emails up to the entire chain of command, including the president of the hospital, saying we are just as understaffed today as when a mother died. What are we doing to get more staff? And the only thing that happened to that was the administration beginning to take retaliatory actions against me for speaking up about safety issues, we never got more nurses. What I did not realize at the time was that, like, literally the same days I was sending emails, the headlines in the news was that Cuomo was holding on to disproportionate share hospital payment that was owed to our hospital that we had already paid, that he was going to hold on to because he wanted us to get used to what it would be like for future budget cuts. The H&H hospital sued and ended up getting that money, but SUNY Downstate isn't an H&H hospital, and it just dropped out of the news. And in November, Tanesia Walker, another Black woman, died of understaffing related causes at SUNY Downstate. So I think it is incredibly important that there is no health equity without equity in health financing. If you give some hospitals twice as much money as other hospitals, they're going to provide better care. And when you overlay that with the state violence of segregation and discriminatory housing practices, this phenomenon, these three hospitals are probably responsible for about half of the disparity that we're seeing. So just a couple more notes. People today have talked about how the H&H hospitals serve underserved people, and I just want to challenge that language and that understanding. If people are underserved by public hospitals, it is us, the public, who is underserving them. And so I want to, often at Downstate, people would justify the suboptimal care we were providing by saying, well, they wouldn't get better care elsewhere. That was the exact same logic used during the Tuskegee syphilis study, that, oh, well, these people participating in the study wouldn't get better care elsewhere, so it's okay that we're doing what we're doing. And that mentality that it's okay to provide worse medical care to people who are underserved, well, no, they wouldn't be underserved if you were providing them adequate medical care. Councilmember Rosenthal, you had asked, if some of the misbehavior on the OB's part was a training issue or a resource issue, and I would offer that it's all of those issues. It's hard to be polite to patients when you have 2 or 3 times the safe amount that you're caring for. The decision-making process of if you're caring, how you keep 3 laboring patients safe is very different from how you could keep 1 laboring patient safe, and it often cuts into the time you have to discuss options and to really get and obtain full consent. But just to bring this full circle, more doctors who practice in New York City are trained at SUNY Downstate than any other medical school. So if we send our med students to a 90% Black hospital where it's okay that women just are dying left and right in childbirth and we don't get the money or the help we need to provide adequate care, and that's the mindset you are trained with as a doctor, and then we send you out into the rest of the city, even if you're now working with a more privileged population, it doesn't necessarily mean you can change on a dime, going from seeing birthing people as subhumans who you can boss around to being fully human that you are interacting with in a collaborative way. So the racism, the structural racism we have allowed to continue at SUNY Downstate is making healthcare worse for everybody in New York City. So I guess and then lastly, we've been talking a lot about midwives, but the 3 New York City midwifery programs are at NYU, SUNY Downstate, and Columbia, all 3 of which are institutions which exclude midwives from practicing in the hospital themselves. So there's this huge disconnect in the way that the organizations who are tasked with training midwives, do they actually respect us? Do they actually see us as valuable members of a healthcare team if they will take our money to give us a degree but won't employ us or hire us afterwards? So some recommendations going forward. I think it's a lot easier. We've talked a lot about what to do about racist providers. I think it is a lot easier to train a Black woman to be a midwife than it is to get a white woman to stop being racist. So I think something to consider would be creating a midwifery program at an HBCU, or perhaps creating like a futuristically Black college or university that has a midwifery program. See how much how much Helena Grant and Patricia Loffman, who testified earlier today, how much would they want to start a midwifery program where we could, if there was perhaps a program with a CUNY college attached to Woodhull, we could be producing 10 amazing Black midwives a year that would over time transform, or could potentially transform, the midwifery scene in New York City. We need to pass New York Health Act, because as long as we have private and public insurance, we are going to have that is the mechanism that the private hospitals are using to cause de facto racial segregation, is by practicing insurance segregation. Insurance discrimination is illegal. It violates 2 federal, 2 state, and 1 local law. But when the New York Lawyers for Public Interest tried to challenge the practice several years ago, Cuomo, who was the Attorney General at the time, refused to take it up. So if we have these laws, but if we're not going to enforce them, I think the other way forward is to just get rid of that mechanism by which we're sorting people. And then lastly, home birth we need to have a public option for home birth. So the midwives who work, we should have home birth midwifery services that are as accessible and perhaps based out of the public hospitals, but that will come and do a home birth, because it shouldn't just be privileged white women who can pay $10,000 out of pocket, who have the option to keep themselves out of these violent places that we've allowed to exist in New York. Thank you so much for your time.
Thank you so much for your recommendations. And I think you'll find a lot of us are aligned. We've been joined by Councilmember Reynoso. You could definitely ask a question. You missed the Woodhull, the whole thing. So he'll tell you his story very quickly. Councilmember Reynoso.
I just want to thank you for this hearing. As usual, the Health and Hospitals Committee is really in the front line of taking on issues that have been foreign to this council in the past, or that we've not addressed in an intentional way. I had my child in Woodhull Hospital with a midwife, or my wife had a child in Woodhull Hospital, and a midwife assisted us. Yes, I got to be very careful. The midwives in Woodhull Hospital have high standards as to how I speak about delivery, so I want to make sure I stay consistent with that. I wanted to just ask, just a numbers question, because Woodhull is also a public hospital, and its rate is significantly lower than these other 3 public hospitals in Brooklyn. Mm-hmm. And the midwifery program is one of those, I believe, is one of those reasons. But do we have statistics related to C-sections and just invasive procedures produced in one hospital that has a similar demographic, like Kings County to Woodhull Hospital? And a midwife told me that a surgeon's job is to do surgery. If they are the ones that are in a room and they have to make a decision, they're going to attempt to use their talent or their profession to solve the problem. If they're not in the room, then surgery becomes something that's less likely to happen. If it's a midwife, they're not going to go in and cut someone open, and so forth. So I just want to know, do we have information as to C-sections and other procedures during birth in Kings County Hospital different from Woodhull Hospital, given, again, same demographic when it comes to the population of people they're serving, both income and race-based?
So, yes, we do have those numbers, and when you look at Central Brooklyn, the role of midwives comes through clear as day, because you have Woodhull, which you have Woodhull with a C-section rate in the mid-20s, low 30s. You have Brookdale and Kings County with cesarean section rates in the mid-30%. And SUNY Downstate has had a cesarean section rate somewhere between 45 and 50% over the past 10 years. So what are the differences between those 4 hospitals? The first 3 all have midwifery services, and SUNY Downstate does not. So you take away the midwives and you get a 15% jump in the cesarean section rate with 0 distinguishing factors between our patient population. We serve, Kings County and Downstate. I can see the one hospital from the other, or across the street. And then when you zoom, we've talked a lot about today about like the midwifery model of care, or just because you have midwives doesn't mean that the patients are receiving midwifery care. And so when you look at the 3 hospitals that have midwives, the reason why Woodhull is doing so much better is because Helena Grant is in charge and they let her run the show.
Yeah.
And whereas at Kings County and Brookdale, the midwife is essentially treated like the director of midwifery is essentially treated like a glorified nurse manager, and they are essentially subservient to the obstetric staff. Their decisions are overrid at any point in time by the obstetric staff with no consultation, with no conversation. I did my midwifery training at Brookdale, and I was working with a midwife with 40 years experience, and a 30-year-old OBGYN came in and told, like, as we were talking with the patient, said, "We're gonna go for a C-section now." And we were like, we're doing what? So it wasn't even, she didn't even, the OB did not even like skipped having the conversation with the patient. She even skipped having the conversation with the care providers. So just like, so I think it is an amazing testament to the power of midwives that even when we are deprived of structural power, there is still a 15% difference than a place where we are not.
Yeah, that's
but
true.
if we really want to see the full benefit of midwifery care, we need to essentially reprimand and hold the obstetric teams at those hospitals accountable for the way they are using their male privilege to subjugate perfectly qualified women from leading in their to the full capacity roles.
And I agree, but having Miss Helena Grant in the hospital makes a big difference.
Yeah.
I don't think anyone can tell her what to do, even if she didn't have the title. But again, I really want to thank you for this information that we're getting and for
Is this
attention
done, baby?
to detail. And I think that conversation about, it's not just about having midwives, it's about empowering them.
Is this done?
Is very important, because I think that a lot of folks are just looking for
Or I guess,
a
like,
place to
some
go
other
where there are
information.
midwives, not understanding the dynamics of what it means to have an empowered group versus just a group that's seen as like a second-hand assistant, I guess. Where in Woodhull, the midwives run the whole show. So thank you so much for that information, and I'm really looking forward to making this a very important part of the work that I do over the next 2 years. So I'm very happy that we had this hearing. I apologize that I couldn't be here for the beginning, but I'm looking forward to meeting with H&H to talk about how we can improve. I want Woodhull Hospital to be the premier baby hospital in all of New York, private or public alike, and we're going to be investing in that. And the reason it got a solid foundation for that to happen is because of its midwife program. So thank you again for the great work that you guys are doing.
Thank you, council member. And I just want to say, with